Morning, guys. Should we make a start? Welcome. I'm Adam Bartlett and my colleague Marius. And this session is the mic? Yeah, it is working. This session is really just looking at liver enzymes and going through a few cases. And first of all, what I'll do is I'll just run through as a surgeon how I think of them, and then Marius is going to sort of pick it up and throw some cases around the room and try and be a bit interactive. We'll work our way through it. Just to give you a background, I trained as a general surgeon at Prince to work on the liver and pancreas. So I see abnormal liver enzymes all the time, but I see it from a surgical brain, where Marius, being a gastroenterologist, sees it from a medical side, and we sort of meet in the middle and hopefully can come up with a plan of attack. And the interesting thing is, with a lot of the conditions here, it's changed a lot over the years. It used to be very medical and very surgical, and now there are a lot of combined sort of treatment of these patients. So I'll hopefully work our way through. Here we go. So I'll just work our way through, first of all, the slides, and then we'll go through the cases. So just to put it out the front there, these are inappropriately named. They're not liver function tests at all. They're actually liver enzymes, because they don't give us any indication of actually the liver function, okay? And you can actually have liver failure, or the liver's not working, with normal liver enzymes or normal liver function tests. And the other thing is with them is that they're not very specific for the liver, okay? There's a number of other factors which can push up your liver enzymes, which you have to keep in the back of your mind. And as a general rule, if you see an isolated elevation of one of the liver enzymes, it's probably not the liver doing it, okay? For the liver, if your liver functions are often more than one, then it may be, or more likely to be, the liver, if that makes sense. So how do you evaluate the liver function? Well, child Pew score was the first sort of method which we used to look at the liver function, which essentially looks at bilirubin, albumin, and INR. Only one of those are your so-called liver function tests, as you can see. They combine it with some sort of clinical things, if they encephalopathy or so forth, and by that you can actually work out the survival. But yeah, time you get to your child Pew C, most people would pick urine liver failure. It's a very crude measure of the liver function. More recently, we've moved to the model of end-stage liver disease. You can't calculate, it's too complicated, so you plug it into a computer and it comes up with a score. The higher your score, the more likely your mortality rate is. Again, you know, there's a lot of people sitting in scores 10 or less with quite marked liver dysfunction, but their mortality doesn't go up. So it's more of a tertiary referral type pattern than you're going to see in general practice, if that makes sense. So none of our tests we have are very good at assessing the true function, and so we're left looking at these enzymes and wondering what to do with them. The first thing is hyperbilirubinemia. Isolated hyperbilirubinemia on its own is really related to liver disease. If you see an elevated bilirubin, it's usually coming from this end prior to the liver, because don't forget, red cells are broken down, they're unconjugated, and then it becomes conjugated, but the bilirubin becomes conjugated within the liver. And most hyperbilirubinemia is either due to a lack of conjugation, Gilbert syndrome, 5% of the European population, of no consequence to the patient. They just go a little bit yellow if they starve or they're sick for periods of time, or it's due to hemolysis. The patient's got hemolysis, not due to liver disease. The quick test for it is just check the conjugated and unconjugated fraction, see how much is unconjugated. If they're not conjugating their bilirubin, then it's going to be likely Gilbert's or hemolysis. So, two patterns of abnormal liver enzymes, okay? Hepatocellular, which hepatitic is the other way, which are the AST and ALT, or cholestatic, which is alkaline phosphatase and GGT. Cholestatic comes from the bile ducts. Hepatocellular or hepatic come from the parenchymal cells, the hepatocytes within the liver. So what about hepatocellular liver dysfunction? What you'll see is a disproportionate elevation in your transaminases. In the community laboratory, you mainly get ALT. When you click liver function test, we're in the hospital, we mainly look at AST. Why? Shorter half-life. So we see, when they're an inpatient, we want to look at daily changes. We're in the community, the longer half-life is probably a better measure. But As I mentioned earlier, it's also expressed in other muscles, the heart, skeletal muscle, and red cells. So these factors can also put up your transaminases. That's released from the hepatocytes when the hepatocytes die. A hepatocellular or hepatitis can have a normal bilirubin, so the bilirubin doesn't help differentiate between if it is true hepatitis or cholestasis. And as I mentioned earlier, the synthetic liver function may be completely normal, yet these could be quite markedly abnormal. So the other group, cholestatic liver dysfunction. You have a disproportionate elevation in serum ALP, and I've put in brackets GGT, and I'll come to that shortly, compared to your transaminases, whichever one you're measuring. Again, bilirubin can be normal. Symptoms of cholestasis often present in this group. What's that? Pruritus, where they're very itchy. Or if you have obstruction, then the patient may have pale stools, dark urine in association. And like with the hepatitic, your liver synthetic function can be normal, abnormal. Doesn't help differentiate between the two. So what about elevation of ALP? It's tricky, ALP, because it can be released by numerous other things in the body, including bone, white cells, kidney, or placenta. If it's associated with an elevation in GGT, it's likely to be coming from the liver. So a normal GGT and an elevation in alkaline phosphatase is unlikely to be hepatitic. As I mentioned before, isolate elevation in one enzyme, liver enzyme, is usually not associated with the liver as a general pattern. And if ALP is elevated on its own, think healing fracture, osteomalacia, hyperparathyroidism, Paget's disease, bone metastases as another cause for it, or a physiological cause such as pregnancy and bone growth in adolescence. You can also see it. What about GGT? Well, it's really too sensitive. GGT just moves so quickly, and it's non-specific. So on its own, it's not that useful. The three areas where I think it's actually useful is if it's elevated with alkaline phosphatase, it tells you it's probably the ALP is coming from the liver. So it helps verify your elevation in alkaline phosphatase is liver related. So is its first thing. If you've got an elevation in the ratio of AST over ALT, where you suspect that it's alcohol-related liver disease, an elevated GGT with that helps give you more evidence that it probably is alcoholic liver disease. Because every patient which you confront over this really sort of says, yeah, sure, I drink too much. You know, they always try and usually play it down. But if you get a ratio of AST over ALT of greater than 2, associated with GGT, almost always it's going to be alcoholic liver disease. And lastly, to monitor abstinence of alcohol. If it's up and you know the patient is drinking to excess, then it's a good measure. Patients actually often like it as a measure to keep an eye on themselves so they know that there's a monitor, if you know what I mean. But GGT, outside of that, normally not that helpful for looking at the liver enzyme profile. So LFTs overlay it. It would be really nice, wouldn't it? One box, the other box. The problem we have, and Marius put this together, and it's sort of like all the color codes, where green is normal, red is markedly abnormal, and this is the gray zone between. And as you can see here, even with cholestatic, for instance, your bilirubin can be normal, marginally abnormal, or markedly abnormal. Yes, ALT is usually normal, but it doesn't always have to be. So there's quite a lot of overlap between cholestasis and hepatitic. And don't forget, if you get marked cholestasis, you will injure the hepatocytes, so you do get some degree of hepatitis with it, or hepatitic picture with it. And likewise, if you get a bad hepatitis, it impedes the flow of bile out of the liver, and you will get some degree of cholestasis. So unfortunately, they don't always fit into one box or the other. It would be nice if they did. So in thinking about it, the first step is it liver or bile duct? Try and work it out. Which is the predominant? Which one's mainly up? Is it new or long-standing? Does the patient give a history, which likely? Usually, by step 3, you've got a fair idea which direction you're heading in. Then you do other investigations based on your likelihood of what's going on. And if you're unclear, it's persistent or markedly abnormal, refer at that point. So this is an example of a patient. So 73-year-old male presented with right upper quadrant pain, jaundice, dark urine, pale stools. Bit of a giveaway even in the history, isn't it, once you see that, what's going on. The bloods, well, we just got colour code them, marked elevation in bilirubin and our cholestatic enzyme, marginal elevation in ALT. So on the basis of patterns, you'd say most likely cholestatic. So ultrasound, next test, shows stones in the gallbladder. Here you can see on the ultrasound here, post-acoustic shadowing in behind. And they noted, not many patients nowadays, you can see the CBD because they're body habitus, but in this patient, they noticed that the CBD was dilated, makes you suspicious, it's choledocholithiasis, that is, stone within the common bile duct. MRCP, confirmed defects in the CBD, consistent with choledocholithiasis. You can see the filling defect here. Proceeded to ERCP, 3 stones were taken out, a large stone was left in there. Okay. Historically, what you probably would have done about this point is go to surgery. Nowadays, people like Marius help us out here quite considerably because we've got this thing called spyglass cholangioscopy and lithotripsy. It's been a bit of a game changer for us because what you can do is a mother-daughter scope. It's like the shuttle. You have the big scope goes down, and through the big scope you put a little scope in, and the little scope goes up the bile ducts. Okay, come up the bile ducts. You can see what's going on. And you can lithotripsy, break down the fragments and pull them back out again. Whereas before, it was probably down to surgery to try and sort this out. So this patient had spyglass with lithotripsy, broke the stone down, trawled the duct clean, and then proceeded to lap chole. Patient's back to normal. He's a dentist by trade, this guy. He went back to work 4 days after all this, okay? So it can be sorted out in combination using both endoscopic and surgical techniques. The next patient, 77-year-old female, non-specific abdominal pain, anorexia for 1 month, jaundice, pale stools, dark urine, pruritus, cholestasis until proven otherwise, okay? Past history of lap chole, 7 years ago, no medications. Similar pattern to the last patient, cholestasis with an elevated bilirubin. Ultrasound showed a poorly defined mass in the head of the pancreas, CT confirmed. Seeing here, mass here, and that hypodense area coming down there is the common bile duct. Is dilated, it's obstructed. I haven't shown the picture here, but the pancreatic duct was also dilated. 2 ducts dilated means there's an obstruction. You have to go down the Auckland Southern Motorway to work that out. And there's a mass sitting right at this point here, pancreatic cancer. Okay, on the basis of that mass lesion, dilated ducts, cholestasis, there's a tumour situated within the head of the pancreas. Treatment, endoscopists. They decompress the patient to allow the bile to come out. Pruritus, it's amazing, isn't it? It goes effervesces almost immediately with that. Endoscopic ultrasound, why? Well, we want to know what it is. Nowadays, we used to operate on these patients straight away on the understanding that there was a 80 to 90% chance he was a tumour, but 10 to 20% chance he took it out for an inflammatory or another condition. Patients were accepting of that. Nowadays, patients aren't accepting of that, so you have to get tissue. So we rely on our endoscopists to give us tissue. Also, there's got a lot of controversy at the moment around should you give them chemo first? Probably is the answer, because you can shrink things, more likely to get clear margins with these patients. So we do rely on endoscopy up front on a lot of these patients. Then prehabilitation for pancreatic resection. What I mean by that, get them fit, get them eating well. There's no point getting them eating well if they're not getting the bile into the gut and not on pancreatic enzymes. So you've got to prehabilitate them to get them in through surgery. Okay? So differentiating hepatocellular from cholestasis, it's pattern recognition. Okay? We sometimes get it wrong. It's not always clear. You can use this thing called an R factor. I can never remember it. Okay, and I was trying to Google it the other night when I was doing this. It took me ages to actually find it on the computer. That can help say, is it the probability of cholestasis or hepatitic? Bilirubin and elevation of liver synthetic function, i.e. that child pupil mount, isn't helpful. It does not help you in telling you the cause underlying. AST or ALT, hepatitic or hepatocellular enzymes, and elevation of GGT-ALP suggests cholestasis. Okay, so that's the gist of trying to work out which one's which. So just briefly going through cholestatic liver enzyme. I won't go over lists and lists because there's textbooks on this, but if you're Cholestasis means blockage of bile flow, either outside the liver or inside the liver. Outside the liver, stones or malignancy, as I've just been over. Inside the liver, it's the little ducts, immune-mediated condition, drugs. Don't forget, viral hepatitis can cause edema. The inflammation of the virus obstructs the small ducts, and you end up with cholestasis. Autoimmune and infiltrative processes. And during pregnancy, we can also see it. So, workup. What do we do? Step 1, take a history, examine the patient. Step 2, you've got to sort of go through the basic bloods for looking for hepatitis C, hepatitis B, and A. Look at anti-nuclear antibodies, iron studies, and antimitochondrial antibody. That's your basic first-line test to try and help differentiate at that point. Then do a duplex ultrasound of the liver. If that's normal, they've got cholestasis, normal ultrasound, you're going to have to look at something a bit more sensitive, MR. It's hard in primary care to get that because getting it done is like, pulling teeth. So you somehow need to somehow look at the bile ducts, and by MR would be the easiest thing to do at that point. Step 4, consider other less common causes, such as EBV, CMV, Wilson's disease, alpha-1 antitrypsin, celiac antibodies, that's all duplicate, I'm sorry. Beta-HCG if childbearing age, is it related to cholestasis of pregnancy? And then if you've still got no answer at that point, refer, okay? Following on from that. The hepatocellular predominant abnormal liver phenotype, so AST, ALT are raised. As I said before, there is either no or mild elevation of bilirubin. They're either symptomatic or asymptomatic. If they're symptomatic, okay, then it's almost always think stones, okay, in people that got pain in that right upper quadrant. And the hepatocellular predominant abnormal liver enzymes is synonymous with what we refer to as hepatitis, okay? And severity and etiology should be, you've got to try and determine how sick that person is and try and work out what is the cause. The likely causes, well, it's viral up the top, followed by alcoholic, drugs, paracetamol. This one's becoming more and more common, fatty liver disease, autoimmune, Wilson's disease, ischemic, it's a normal giveaway, they're incredibly sick with it, or malignant infiltration of the liver. The pattern of the AST and ALT can be helpful. I mentioned this before, alcoholic liver disease, AST always thinks spirits over the liver. So if it's greater than 2, that usually indicates alcohol. In NAFLD disease, which is, as I said, we're seeing so much more of it, the elevations are moderately elevated, but not very high. Acute viral, they get higher. Ischemic, very high, okay? And don't forget, if you've got chronic HCV or HBV, then it could be normal, okay? And we'll go over the cases a bit later related to this. The level of your transaminases doesn't always, in chronic viral hepatitis, go up. Workup, same. It's the same workup in terms of going down these patients, okay? In terms of the history, the bloods, the ultrasound, other causes, and then refer if at that point you're stuck. So let's try and go through some examples. I'll hand over to Marius. He'll go through some different examples of abnormal LFTs.
So I thought we'd just go through a few different examples, because the hardest bit is you get a patient in, they're diabetic, you do a blood test, and the LFTs come back abnormal, and then you go, the patient's gone, what do we do? And then quite often is, with all of these things, you can put a slightly different medical history to the same liver function test, and you actually get sort of a different answer. So sometimes it's a little bit of a puzzle. And the main thing is like I said, if it's coming from the liver sides, the bile ducts can get a bit obstructed. So quite often, nothing's really up in isolation. And then the first step is really, well, what's higher? Is it the ALT, AST higher, or is it really cholestatic, ALK-Phos and GGT? The second thing is, well, is it new or long-standing? This is a patient that had this fatty liver disease and has been going on for 10 years, or is this something really new? And then really the history will most likely give you the right thing. But like I said, it's pretty easy because you normally send a blood panel. If you're unclear, do an ultrasound. If you're unclear, you just send it off to a colleague. So we got here at 50-year-old diabetic man, just routine follow-up, and all of this comes back, and you go, oh, yes. So how would you call this picture? It's nice I've color-coded it for you as well. So it's basically everything. So you would basically say it's all mixed. So yeah, it's a bit up there, a bit up there, and this is most likely what you'll find. So again, most of the time this will be your non-alcoholic fatty liver disease. And the question is, well, we've got so many of them, 30% of the population is obese. What do you do? Which one do you send? Which one do you keep? So the easiest thing is sometimes just doing one of these online NEFL fibrosis score. The main thing they put in the calculator is actually platelets. So if you've got somebody that's got really low platelets, abnormal LFTs, or the INR is up, then you know you've probably got cirrhosis. So the nice thing is the fibrosis score. If it's all normal, they're unlikely to have cirrhosis. Sometimes it comes back as indeterminate or high. If that's the case, you can refer for a FibroScan or just send it off to a hepatologist and he'll sort that out. Right, so the next one. 25-year-old says had some urinary tract symptoms. She's just doing LFTs and oh yeah, the belly's up. Exactly, yeah, Gilbert syndrome. They're a little bit sick. You can do a conjugated if you want to, but most of the time they're already gone. So this is just explained. It doesn't really make any difference. One of my colleagues says he's got Gilbert syndrome and he actually boasts that they live longer than the rest of the population. So he thinks it's a good prognostic factor actually. Right. Now we've got a 60-year-old recurrent UTI. Should do another LFTs. What sort of picture is this? Yeah. So where's the problem? Is the problem in the bile ducts? Is the problem in the liver? Yeah. So this is mostly a liver problem. So then your question as well, most of the time then history gives it, so I'm giving it a sort of a way, 60-year-old recurrent UTIs. What are the most common things? Sometimes we can see abnormal LFTs because what we do to the patient. So in this case, it's most likely nitrofurantoin that brings up your LFTs. So the first thing you do as well, is it something we've given it? Is it some drugs, mostly antibiotics that does it? And the other thing is herbs and supplements and all the weird and wonderful liver detoxes and fads you see on TikTok that can sometimes also set things up as well. So most likely sort of stops. If you just keep on going, you'll see ALT will go up to 500 and 600. But again, there's something brewing. Are we doing it or is it something else? But you would still send off a normal panel anyway, because you can set off your autoimmune screen and a few other different things. But that's what I mean. The same LFTs, slightly different heading, and you've actually got a slightly different answer. So it's mostly a guide, these liver tests. Is it liver, is it bile duct? And then with the puzzle of the patient, you can sort of put it all together. All right, so now we've got a 35-year-old pregnant lady. We just do the routine bloods. ALT comes up to 90. You do a liver screen, and it comes back with an AFP of 800. Shit. Well, I've actually, once a year, I get a phone call of this, and it's actually, what's happening here? Exactly. It's alpha-fetoprotein. So, but it actually causes quite a bit of anxiety because you do think, oh, that's great, the ALT comes up, we'll do a normal liver screen. So it's actually hepatocellular. So it's most likely a hepatitis B. Sometimes it can go up in pregnancy. You can get some weird and wonderful things. The main thing to look for your hepatitis B is the viral greater than log 6, so greater than 1 million, because if that's the case, then you would need to give the mother antivirals to protect the baby from getting the virus as such. But yeah, I get about a phone call once a year saying I've got a pregnant lady with liver cancer. All right, so now we got a 60-year-old female, intermittent abdominal pains. What sort of pattern is this? Is it the bile duct? Is it the liver? Bile duct. So you got bile duct and pain. What that normally indicates? Stones. So it's usually cholestatic, most likely gallstones. Ultrasound is best. If it's still unclear, you can do an MRI scan. If it's still unclear, I probably see it once a month where somebody comes, oh, it feels like my gallstone is playing up. All my scans are normal. I do an endoscopic ultrasound and actually find just the stone that's bobbing up and down. All right, so we got another one. 50-year-old alcohol dependence comes in jaundiced. Pattern, you would say, liver, bile ducts? Bile ducts, yeah. but you know she's sort of alcoholic. So again, it's sort of cholestatic. So if I see this particular picture, I think about two different things, and I'm not sure if anybody... Sorry? Yes, not really, because they're sort of just jaundice. Pancreatitis is normally pretty painful. So pancreatitis, normally they get pain, you get these enzymes that digest meat in the abdominal cavity. So it's usually quite sort of painful if you're looking at pancreatitis. It's sort of a misnomer because I would still can call this either an alcoholic hepatitis. And the one thing is it's sort of wrong in the name, because most of the time when people come alcoholic hepatitis, they're mostly jaundiced and the ALT can't even be normal. Or the other thing is they're actually just stuff their liver up even more and they're actually jaundiced. So the alcoholic hepatitis, it's more of a shock where they've had such a big binge of alcohol. The liver almost goes like in a shock, doesn't get rid of the bilirubin, they got really, really jaundiced, so it's usually cholestatic. Or the other thing is they've just killed enough liver cells. There's not enough ALT, even they haven't got enough liver cells to pop and die anymore, so the ALT sometimes can even be normal because they don't have much liver cells and the liver is sometimes failing. And then you would check your INR to see which one is it? Is it all normal or is it actually they're really decompensated? All right, next one, 40-year-old female, presents with fatigue, like most of your patients. They're normally in thyroxine, but you check their thyroid function, they've actually got normal TSH. What sort of picture is this? Liver or bile ducts? Yeah, liver, everything else is normal. You can even put sometimes like 200 or 300. I've put it a bit more clear, but most of the time when you get these backs, your ALT will be 700 and your ALK phos will be 300 or something like that. So you sometimes just got to pick one, which one is the predominant one. So what sort of things would you be thinking here? Well, the normal thyroid, so you've already checked that and you're a good GP, so you've checked that already, so that's nice. Yeah, so quite often, particularly female, they've got one autoimmune problem. If you're predominant, your immune system is a little bit overreactive. Quite often we see that one immune problem gets another problem. So somewhere around 500, so it's hepatocellular, most likely an autoimmune. But again, you just do all your normal blood test, SMA, and particularly once it's above 500, we get sort of a little bit nervous about, well, how quickly are they burning through the liver? So if it's somewhere around like up to 200, yeah, you can do a screen, but if you start to get above 500, then just call up one of the gastroenterologists and send an urgent referral through. If they're over 1,000, then we're really getting panic stations, basically get them into hospital, do some tests, do a liver biopsy, see if there's anything else that needs treating. Smooth muscle antibody. All right, so the next thing, now we've got yeah, so you can see almost the same thing. So I had a 30-year-old now, presents with fatigue. She's trying all these little TikTok things, so she's been trying to lose a little bit of weight, the exact same liver pattern. So is it liver or is it bile duct? Yeah, liver. What do you think's happening? Yeah, she's taking a supplement. Do you know which one is the most common one we see? Green tea extracts. So drinking green tea itself actually makes your liver enzymes longer. Most of the time, all these supplements and things, they've got green tea extract as an appetite suppressant. So that's the most common one we see. So it's all those fat boosters and protein powders and things don't really do it, but it's just all those sort of fat, pre-workout, fat boosters, all those sort of weird and wonderful detox things. Yeah, of course. Yeah, so particularly if it's above 700, I would still do a blood test and basically check it probably at least every week. Sometimes what happens is they come in with this and then sometimes it goes through cholestatic picture. So initially they've got a liver injury and then they can get some secondary cholestasis. Everybody sort of slightly goes different, but you would definitely keep a very close eye on this and then at least weekly blood tests while you sort of weight things up as well. Because 700, that's pretty high. So I think I've only got one more case left. So now we've got a 60-year-old, same thing, fatigue, not on any medications. You've got a normal ultrasound. So is it liver or bile duct? Yeah, so bile duct. So this is a slightly trickier one. So then you go through this whole long list of cholestasis, which we've got, and like I said, you can make textbook of it, but that's typically age, sex, 40-year-old female. That's normally primary biliary cholangitis, but it's the same thing. You do a full liver screen, gastroenterology referral, you do an ultrasound. If I put up on there, they've got weight loss, then you think cancer. So all of those things, the liver test just indicates to you, is it a liver problem in the liver itself? Is it a bile duct? And then it's just really sort of a little puzzle that sort of works things out. So common, basically, it's not really a reflection of liver test. If you're looking at liver function, you really want to iron and albumin, although the albumin goes down when people are sick anyway. And then really, which one is the predominant picture? And then you sort of work out as a little puzzle. Is it all new and high and quite panicky, or has this been going on for the last years, and then sort of trying to sort of work things out? I'm not sure if you've got any particular burning questions or problems that you quite often see in. Yep.
Is it universally we don't do AST with liver function test?
Yeah, it's sometimes a little bit annoying, and particularly once you then, the lab mainly just does the ALT. And then the problem is if you want to do some of these calculators where you're saying, have they got cirrhosis or hepatitis C has come back, and then you want to say, well, have they got a fibrosis score, then these damn Americans, they always use AST. So they always like to be different with pounds and liters and gallons and things. So then it sometimes gets a little bit tricky. Most of the time, ALT and AST are fairly comparable. So sometimes you can actually still put the AST in the calculator as a similar indication. Because most of those calculators, they go of INR and platelets. So it's sometimes annoying because it comes back and you're saying, oh, great, follow the pathway, I'll do a fibrosis score. Actually, I can't do one because there's no AST. But that's just the way the lab works around here. They normally don't do an AST routinely.
In the hospital, really the opposite. So the hospital, lab is AST and ALT. In the community, it's ALT. It's because of the longer half-life.
Yeah.
So you shifts quicker with AST.
Yeah.
So if you measure it in daily, AST will move, ALT probably won't. That's why the laboratory is community monitoring versus hospital monitoring. But it would be helpful, wouldn't it, to do both? Particularly trying to work out etiology. Is it alcohol related? Is the ratio, or is it natural? Correct.
Yep.
You just ring and they do it, yeah, they'll
Yep.
add it to it. But have you run the lab recently?
Yeah. Oh, nice.
Yeah.
Good. Excellent. Good tip. Yes.
The Intel score that you've shown, as opposed to the EPRI score, do you, like if you put in your obese patient into an EPRI score, are you going to be wrong?
No, because the EPRI one, again, depends which sort of protocol you do, because the EPRI, quite often we use it for hepatitis C, so whether you can treat them in the community. All of those scorings are fairly similar. They've got slightly different things. It's all just an indication. So most of those ones are really good for excluding cirrhosis or significant fibrosis. But most of the time, if you get a borderline and it says indeterminate, so it's really good for excluding. It's not really good for being sort of specific for things. So it's set up as just an exclusion score. So it's very sensitive. It's really not very specific. So yeah, you can use one or the other, and they're quite often similar. But yeah, we always get quite excited saying, oh, that's nice. There's an EPRI score, an EFL score, or something else in there. But yeah, you can sometimes use both. Yes.
So post-Nambra treatment usually, should we be using fibro scans for people routine?
So the interesting about the fiber scans is that quite often they do change afterwards. So there's less the fiber scan. What it does, it sends a little flick like a sound wave sort of through, and then what it does, it sees how much fibrosis, how stiff the liver is. So it actually sees how much the liver jiggles. So if there's inflammation, the liver also gets stiffer and sort of jiggles less. So quite often after treatment, the liver stiffness reduces is not necessarily we think that the sort of the fibrosis actually has changed, although sometimes it does. But it actually, quite often you treat and then the score always becomes lower. The trick then is as well, if you think they're cirrhotic, so therefore they're at risk of getting liver cancer, then we won't really routinely do a FibroScan afterwards, because even if the FibroScan is normal, we still think they've got significant amount of liver fibrosis, so therefore they're probably still at risk for a liver cancer, and we would still necessarily follow them up. So if it was me, then I was saying, great, they treat it. The main thing, you treat them in the community, so quite often we think they're not cirrhotic anyway, because the cirrhotics quite often get sent to us. So we normally wouldn't routinely do a FibroScan after hepatitis C treatment. Yeah, but the main thing is if we think, great, they're not cirrhotic, it's all great, it's cured, then we don't necessarily need to do any additional monitoring as such. Hepatitis B gets different because obviously that's a chronic infection, so you would obviously, even if you put them on treatment, we would still quite often monitor them depending on what other risk factors they've got. So we normally wouldn't routinely FibroScan people after Hep C treatment. Yes?
You have specified additions into liver cholestatic picture. What happens when you have elevated enzymes right through all the liver enzymes are elevated and they're closely elevated?
Yeah.
What are the differential diagnoses? That's number one. Number two question is about FibroScan. Now working provincial pharmacy, we don't have access to FibroScan. What's the next best thing we can do?
Yeah. Well, I guess that's the fun thing. If all the tests are up, then it just comes back down to what do you think is going on. And then the nice thing is, well, you've got a lovely panel of blood tests that may give you the answer. You get an ultrasound that may give you the answer. And then depends on just how high things are. If it's just a little bit up and it's chronic, then you've got a bit of time. If it's all going up really crazy, then the easiest thing is just give us up a ring or send an urgent referral through and just ask for some advice. But that's the hardest thing is they can go up with everything if you get sick, if you're really septic, if they've got other infections. So it's not very specific. It's all more just an indication of where do you think the problem is, and you've always got to put it back in the context of the patient. The second thing is with the FibroScan. So where are you based? Yeah. So sometimes it's the again, you can use the EPRI or the NEFL sort of score depending on sort of what they've got. I'm not sure. The whole thing about this Tafata Aura, it's supposed to make access much better for everything. Actually, I found it's completely the opposite. Whereas previously, people you come from Northland for sort of fancy ultrasound procedures or other sort of things, and managers got paid for it. Now with Tafata Aura, they've actually completely abolished the interregional funding. And when I got a patient now, my manager says, well, we used to get paid for that. We not get paid for it anymore. Do you really have to do it? So it's actually making things harder to actually do patients out of regions than rather easier. But in theory, if you're sort of concerned or you want to do it, I'm not sure, can you refer on to like a bigger tertiary center, or is there like a referral stream? Yeah. Yeah.
The other thing you get to there is if you've got a mixed picture and you still don't know what's going on, this biopsy, but not in the community. But we used to do.
Yeah.
We used to do.
Yeah.
It's not that long ago. We used to do a lot of biopsy because we didn't have the FibroScan. The FibroScan was a big change to us because you're trying to work out is this person progressing, particularly for Hep C or other conditions, and FibroScan eliminated that. So now when we say biopsy, everyone goes, what? What are you doing? But we do get stuff. But what we do at the end of the day is biopsy. And then we get this stuff.
You ever presume trying to use like a cellular picture? Does that approach is a write-off in the future? So if it's not very time, maybe they've had two relatively recent courses, should they just be done actual penicillin, whatever it is you suspect that they've got one?
It really depends, and the main thing that I do is I basically Google it, fancy Google. So it comes down, so you've got liver tox. So if you look at liver tox, that's the NHI, so the American system where everything is in there. And they basically tell you what's the likelihood of the drug causing it. So saying, nitrofurantoin, we come in and actually said, this is a hepatitic picture, this is the typical pattern, this is what it normally does. So the nice thing is well, you think it's a drug-induced, I look up the latest evidence that's going on, and then saying, this is there. The main thing is we've got so many different drugs these days, it's rarely a problem that you're saying, I can only give nitrofurantoin, or I can only give penicillin, or I can only do such a thing. So most of the times it's just alternatives. So we normally wouldn't necessarily re-challenge. The other interesting thing is as well, particularly then saying, look, I've got a patient with liver cirrhosis. They've now also got high cholesterol and all these other different things. How safe is the statin? That's another sort of common question I get, because people are going, oh my God, the liver's not normal. Can I still give statin? Can I still give paracetamol? And the answer to that is yes and yes. So quite often what we do is we actually know that giving a statin with people, it actually reduces liver cancer risks. If you look at the studies, it reduces portal hypertension. So a low-dose statin is very safe in people with sort of liver cirrhosis. It's the same thing, paracetamol, you wouldn't necessarily give them full dose, but you can easily give them like 500, three times per day. So you wouldn't necessarily give them full dose, but you wouldn't necessarily exclude statins or just some low-dose paracetamol if they've got pain, for instance. Yes? Yeah, sometimes you can do a lipase, but the interesting thing about lipase, it's quite often up sort of 300-400, and then you go, and we normally just ignore it. So yeah, but if they're getting pain, then it goes up. But these are sometimes then the young patients. They got pain, a bit of abnormal LFTs, and then the lipase comes up, and then they usually end up being seen by a specialist. Well, could this be this magical sphincter body dysfunction that we get a lot of referral for, which everything's sort of changing in the literature now, that we don't actually think it's much happening, and it's more sort of a regional and functional pain. So in the end, yes, lipase sometimes we do add it on, and it sometimes comes up, and sometimes we just don't know. Yes.
I suppose that there are different race cutoffs for some of the LFT enzymes.
Hmm.
I think Asians in particular expect lower groups. Does the lab will have to factor that in when you get the test, or do you kind of have to have some awareness that maybe this is a high for this race, even though the normal group or maybe it's mildly unfair?
Yeah, I don't think they really take that into account as such. But most of the time, if it's 30 or 50, usually that doesn't really make that much of a difference in sort of in your interpretation, I think. And that's the thing with all of these tests, it's like the way they make a normal range, they get a whole group of army volunteers, they're bell curved, and they say 95% of the normal people are normal. So if you're going to do 20 tests, you're going to get one which is falsely positive just by chance as such. So it's the same thing when you do the autoimmune panel, particularly some of the auto antibodies. Quite often you get the AMA or the SMA, which is weakly positive, and the patient hasn't got any symptoms, and the liver tests are normal, and then most of the times you just ignore it. Or sometimes just saying, we'll do the LFTs in a year's time. But that's the whole thing about testing all normal ranges. Normal is overrated, and normal sometimes gets a bit boring. So. Any other questions? Or no? Looks like we've got coffee time. Right, thanks for your attention.